Bueno, espero que todos estén disfrutando de su almuerzo. En la tarde de hoy, de parte de PTY Medical Group, tenemos el honor de presentarles al doctor Hamgad Haleem. Él es un profesor asociado de cirugía ortopédica de pie y tobillo y de cirugía compleja de extremidad. Es director de investigación del Hospital de Oklahoma y director del Departamento de Cirugía Ortopédica de la Universidad de Oklahoma de las Ciencias de la Salud. Con ustedes, el doctor Hamgad Haleem.
Gracias, doctor González. Hola, buenas tardes. No hablo español, pero quiero saludarlos a todos en su idioma. So that's all I'm going to say in Spanish. I hope you're enjoying the meeting. It's an honor to be here. I want to thank the Panama Orthopedic Association for inviting me, PTY Group, Gabrielle, and Vilex Medical. And I know there's not a big foot and ankle community here. I talked to Dr. Moreno and Dr. Gonzalez yesterday. But I think during lunch break, picking up on some foot and ankle stuff would not be bad for you. So I thought the title of my talk today would be How to Save the Arthritic Ankle. When we're general orthopedic surgeons, we do fusions. We're very happy and very comfortable doing ankle fusions. But when you have a patient come with ankle arthritis and they have good range of motion, you really want to try and preserve that motion. So how and what are our options to do this? I have to disclose that I consult for Vilex Medical as well as some other companies. And this is my background. I'm originally from Egypt. I played professional basketball over there. I was team physician and I had some trophies. And then I came to the US, did my training in New York in Cornell. I did 4 fellowships, and then I went to Oklahoma. This is my family and this is my country. Egypt, like Panama, is a beautiful country, and we have a lot of things in common. The country is beautiful, the traffic is horrible, and people are always late. It's okay, I understand. So, my practice is 70% foot and ankle. I also do a lot of deformity correction. And I do a little bit of hip and knee replacements just because I'm in a level 1 trauma center. I chair the department where I sit as a director of research, and most of my research is in cartilage restoration. I'm trying to save joints from arthritis. So we all know that ankle arthritis is a big problem. Ankle, unlike the hip and knee, it doesn't come as idiopathic or primary arthritis. It's usually post-traumatic after accidents, pilon fractures, ankle fractures, and it's usually happening in the young, relatively active patients. So when you have this patient population at a younger age that are relatively high demand with good range of motion, you definitely do not want to fuse them. I'm not saying there's something wrong with a fusion. This is a patient of mine. I did a fusion on him, and can we play this video, please? I just saw him in clinic the day before yesterday, before I came. Video. So he is 4 years out of an ankle fusion. And this is how patients with ankle fusions walk. They're very happy. They love it. If you do an ankle fusion correctly, no problem. The only problem is that, again, we found minimal difference in gait, in walking, in patients who have fusions versus ankle replacement. But down the road, every single patient you give a fusion in their foot, you have to tell them that in 5 to 15 years, they will have what's called adjacent joint arthritis in the subtalar joint in the midfoot. So this is a problem. And if you don't tell your patient that, they will be mad at you. It will not be their last surgery with you. A fusion is not the last surgery. And that's why we started thinking about options to preserve the ankle motion and preserve adjacent joint arthritis. So you have 3 options. The first one is something that you will all know, which is called a supramalleolar osteotomy, or cutting the bone, just like with the knee. I have bow legs. I am going to get a high tibial osteotomy at one point. to preserve my knee. I'm relatively young. I'm in my mid-40s. I do not want to have a knee replacement at the age of 50, so I'm most likely going to get an osteotomy. The second option is called distraction arthroplasty, where we open the joint up and create a false joint that is filled with some scar tissue that allows the patient to walk. And the third one is going to be the focus of our talk, which is total ankle replacement. So the supramalleolar osteotomy works in malaligned ankles. If you have a malaligned ankle, good joint space, good range of motion, this in a young active patient and a healthy other side can be a good indication. Now, there are rules. So there are two classifications. The first one is what's called the Takakura classification, and most of us know it, and that's if you have varus arthritis. And the other one is called the NUP classification. When you examine the patient with asymmetry or malalignment, you have to examine the knees, the hips, and the ankles. So you have to get full alignment films of the patient. You always have to examine the deformity and see if it's flexible or rigid. This is a golden rule in foot and ankle. When you have to operate on these patients, you have to pre-operatively plan your osteotomy because you can overcorrect or undercorrect a patient. So this is how I did his osteotomy. You have to break the fibula because it goes hand in hand with the tibia. And then pre-operatively, I measured the wedge I'm going to make out. So now my first cut is going to be, my first K-wire is going to be perfectly perpendicular to the long axis of the tibia. This is where I want my ankle to sit. My second cut is going to be at 20 degrees, which is the amount of correction. So I put a K-wire and I go with my saw blade over the K-wire, and then I close the osteotomy. And then once this osteotomy closes, your ankle is going to be perfectly straight. Then you fix the tibia, fix the fibula, put bone graft, and make sure you always fix the syndesmosis. This also is the side view. Make sure that on the lateral you're not creating another deformity. And this is the patient 2 years after the surgery with a perfectly aligned ankle and very happy in a young patient. This is another difficult case where the patient had a fracture. She was fixed at an outside hospital. I'm sure you see in Panama a lot of these fractured patients with deformities. She comes to me with this very bad deformity, and it's in two planes. So in the front view, it's in valgus. Here, it's in recurvatum. So when you do the osteotomy, these are the long alignment films to make sure that her knee is aligned. You can see she has a total hip and a total knee. She is not a good candidate for a total ankle. So if you do a lot of deformity correction, you know that you have to create a biplanar deformity, a cut in two planes, to make it perfectly straight in the AP view, but also straight in the lateral. And then you fix the osteotomy, and in her case, because she had some ankle arthritis, I fused her ankle. So this is both a supramalleolar osteotomy and an ankle fusion. Next slide, please. There is another osteotomy, which is called the dome osteotomy. This is very nice if you do not want to lose length. Because sometimes if you do a closing osteotomy, you're going to shorten the leg. A dome osteotomy, just like the knee, there's a dome in the knee, can prevent shortening, and this is a good option. So the results of the supramalleolar osteotomy have been described, just like in the knee, and they have very good results with 85% survivalship at 10 years. So again, for the young, active patient, this is going to buy you a lot of time. The second concept that I don't know whether you know about it or not is ankle distraction. Dr. Mourinho and Dr. Gonzalez and the foot and ankle guys told me that you don't have a lot of circular frames here in Panama. But an ankle distraction basically relies on getting the arthritis, cleaning the ankle out, applying an Ilizarov ring fixator, and distracting the joint while putting a hinge to allow motion. And when you do this, you actually get very good results. So this is how you do the technique. When you put the frame, you open it up, the joint becomes wide, you put hinges, patient can walk on the frame. The only thing is he's in the frame for 3 months. And after that, you take the frame off. I published our results on the short-term results of the magnetic resonance imaging after ankle distraction. And we found two things. Number one, patients have good space after the surgery. This is 1 year. This is 2 years. Patients actually have better MRIs. When you get follow-up MRIs, the edema in the bone, the cysts in the bone are better. And we found on MRI also that there is some sort of scar cartilage. It is not pure cartilage, it is scar tissue that forms in the joint and gives us good results. Patients are usually happy, as you can see here. This is a very nice cartilage scar-like layer. Patients are usually very happy with this surgery. And when we asked our patients, 84% of these patients said they were happy with the surgery and would have it again. So this is an option that is very nice and very good for you to consider in the young patient with post-traumatic arthritis. The 5-year survival was also 84% at 5 years. This is a relatively new technique, so we're looking at our long-term results with it. Now, this is a case that I would like to show you. So this patient came to me with, initially, she had 13 degrees, and then after a year, she had 18 degrees of varus. It became worse. She did not want a fusion. She was young. So this is what I did. I went in, fused her syndesmosis. I did a supramalleolar osteotomy, and I did an ankle distraction. So here I'm using both techniques, a supramalleolar osteotomy and an ankle distraction. We kept her in the frame, and you can see her bone here after I made her ankle perfectly straight. The ankle is distracted. The bone continues to heal. This is her filling up nicely with the frame. This is, again, an Elizarov frame. And then we took the frame off, and this is her joint. Bone is fully healed. Joint is wide and nice. And this is her video. Can we play that video, please? Video? She is very happy with the outcome. She is 30 years. She is 3 years out. She has no pain in her ankle. So this is a very good option, again, for patients who want to maintain the range of motion. Can we play the video? So this is the ankle we operated on, and this is the other one. Pretty good range of motion. So another good option to have in the back of your mind. Now the last one, total ankle replacements. I know you had the total ankles in Panama for a while, and then they were gone from the market for some issues, marketing and financial, and then they're back again. So as I told you, a patient with an arthrodesis or a fusion is going to be walking fine. But down the road, they're going to develop arthritis in their ankle and their hindfoot. Now, this is not the case with a total ankle. If you do a very good total ankle, you will preserve motion, you will prevent adjacent joint arthritis. The studies have found that patients with ankle replacements are anywhere between 80 to 97% happy, but it is not an easy surgery. Beat Hintemann out of Switzerland, when they look at the Swedish registry, found that you need at least to do 30 total ankle replacements, just like hip and knee replacements. 30 surgeries before you're confident and do them well and have good results. So this is something that does need training. For me, a total ankle replacement, unlike the osteotomy and the distraction, the patient has to be relatively older. When patients say how old, I would tell them 50 years, 55 years is what the golden rule is. But now we have better implants. We have tantalum metal, we have vitamin E poly, so we have longer lasting implants. So we come down with the age a little bit. So 50 years is not a bad option. I'm closing up to 50, so I would be a good candidate for an ankle replacement. But also, other than that, you should think of what the data has to say. When we came out with the first generation ankle replacement, the survival was very bad. They did not last more than 5 years. Now, Beat Hintemann out of Switzerland did his study on 683 patients. This came out of JBJS 2022, and we all know JBJS. 20-year survival on 683 patients, and the survival rate was 93% at 5 years, 86% at 10 years, and 82% at 15 years. So it's very close to the hips and knees. We have very good results with very good data. The only thing is aseptic loosening. This is what we're struggling with. But now we have the porous metal, just like you have in the cementless hips and the cementless knees. These ankles are cementless as well, and they have very good survival. Can we play this video quickly? So this is a quick video of the surgical technique of the Hinterman total ankle, and of course I have disclosures again. But basically, a total ankle is like the total knee. I always think of it because it's a hinge joint. So what you want to do is you want to put an extra medullary guide on the ankle, just like we do with your knee. And this extra medullary guide is going to go on the tibia. And you're going to align it to be perfectly parallel to the tibia. Once you do this, you're going to make sure that you don't have a varus or valgus cut. So this has to be perfectly straight up and down. And then you have to make sure, just like knee replacements, you are not malrotated. Your rotation has to be perfect. And for those of you who do foot and ankle work, we all know that the rotation of the foot lines up with the second toe, toe number 2. So we line this up with toe number 2. Just like the knee, we pin this down, and then we start doing our cuts on the tibia. Before we do the cuts, we check our alignment, and this is to make sure that we are perfectly perpendicular, and our cut is going to be perfectly perpendicular to the long axis, and then the amount of bone we are resecting is going to be adequate. So this is the mark for where bone is going to cut. Then we go in and we do our tibial cut, as you can see with the saw blade, and then we do what's we call the gutter cut, just very close to the medial malleolus. And this is a very big problem because you can't break the medial malleolus when you're putting an ankle replacement. And then we open this up, lock this, and then we do our talus. We cut the talus. Again, just like with the knee, you cut the femur, you cut the tibia. Here, we cut the tibia, and then we cut the talus. Once we have the talus cut, it will be about making the chamfers. On a total knee, you have the femur, you have posterior chamfer, you have anterior chamfer. Same thing here. We measure the tibia, we put the tibial tray on, and then we're going to put this instrument on the talus to make our chamfer cuts on the talus. In the total knee, the chamfers are on the femur. In the total ankle, the chamfers are on the talus. Once you put this in, you pin this down, and then you put this small thing here to protect. Again, you're going to protect the medial malleolus, and then you do your posterior chamfer, and then with the burr, you're going to make the anterior chamfer. And then these are the side chamfer cuts. So the talus, as you're going to see, is going to go in with minimal bone resection, just like the femur on a total knee. Once our chamfer cuts are made, we take everything out, and then we put the trial talus on, and we measure our gap. Those of you who do knee replacement know what's called gap balancing the gap. So here, we balance the ankle, just like we balance the knee. Check the ligamentous laxity. Once I've done this, this is going to finish my anterior chamfer on the talus. And then once we're done with that, the talus is done. We're going to put our definitive components, our implants. So 2 drill holes for the pegs, just like the pegs on the femur. And I do knee replacements and hip replacements a lot. That's why I keep telling my residents when I'm training them, it's very much like a knee. The talus component goes in, the tibia component goes in, and then you can try the thickness of your poly, just like you do with the total knee. You put different polys until you get the adequate thickness. You test your ankle, you like where it is, and that is your surgery. This is your total ankle. Took me 2.5 minutes to show you the video. It takes you 1.5 hours to do the surgery. Can we move on? Yeah. So what have we started doing different in total ankle replacement? In the old days, we used to do an anterior approach. And I was talking with Dr. Moreno yesterday. If you do an ankle approach and the wound breaks open, you will have the tibialis anterior tendon looking at you. This is a big problem. You're going to call plastic surgery to come help you. If you do this modified anteromedial approach, which was described by Tim Daniels in 2020, so you take your incision, go to the medial side, and come back. Your tibialis anterior tendon is going to be protected by this thick flap. And then you go in and expose the ankle as usual. It protects the superficial peroneal nerve. It protects the tibialis anterior tendon. So this is the approach. The other thing we talked about yesterday with your foot and ankle group is fixing the medial malleolus before you put your total ankle in. Because if you do this, you're going to avoid this problem happening, which can happen a lot. 30% of the time, the medial malleolus is going to break. So you have to be very careful, and if you're starting to do these, fix the medial malleolus. So my other tips and pearls is you have to do what's called soft tissue releases, like a knee replacement. If you have a varus knee, you're going to release the medial ligament. If you have a valgus knee, you're going to release the lateral ligament. The same principle applies in total ankles. So release the deltoid and reconstruct the lateral collateral ligament if you have varus. If you have valgus, then you have to reconstruct the deltoid and release the lateral collateral ligament. The last thing is lengthening the heel cord. A lot of patients with ankle arthritis are going to be in equinus. They're going to have a very tight Achilles. So always have a very low threshold to lengthen Achilles, lengthen the Achilles. It's going to help a lot the range of motion. And then the other thing is correcting your hindfoot. Why? Because your hindfoot, your foot, is the base on which you're going to put your ankle. So you want to make sure that your foot is perfectly aligned. So if you have a flat foot, reconstruct the flat foot. If you have a high arch foot, a cavovarus foot, reconstruct the foot first and then do your ankle replacement. Not like the knee, where you do the knee first and then the ankle. No, actually you have to do the foot first because the foot is the platform, the base on which the ankle replacement is going to sit. So address any residual deformity, cut the heel cord, cut the calcaneus, and do your flat foot reconstruction with a cotton osteotomy or a reverse cotton if you have a high arch foot. Finally, I'm going to show you some cases of ankle replacements. So this is a patient that came with bad ankle arthritis, 10 degrees of varus, but 10 degree is okay. It's not that bad, just like a total knee. So we went in and put in a primary total ankle in her and just did the medial deltoid release with no lateral collateral ligament reconstruction. I put in a slightly thicker poly, so the joint became tight and it's very stable. Now this is a different patient, and I showed it to Dr. Moreno and the group yesterday, 25 degrees of varus. Now this is a big deformity. This is one that you have to put in a revision prosthesis, a stemmed implant. You have to release the deltoid, but you also have to reconstruct the lateral collateral ligament. Can we play the video, please? So this is the patient 3 years after a total ankle, pretty much walking normally. If there was sound, you would hear her say, I did things I could not do 5 or 10 years ago. So just like the patients who have knee replacements tell us, they're happy with their knee replacements.
Wow, that's amazing.
Patients are happy with their ankle replacements. Now, this is the third case, which I struggled with. Again, now this is a bad flat foot. The patient had an ankle fracture, she had a valgus injury, but she also had a flat foot deformity. I got her CT, and she had arthritis in her hindfoot. So I went ahead and fused her hindfoot first, then came back again, took her hardware out, did a supramalleolar osteotomy and a deltoid reconstruction. I thought that the supramalleolar osteotomy is going to do her well, but she continued to have pain. So I went in and I did a total ankle replacement with a revision prosthesis. This is her range of motion, and this is how she's walking. She has back problems. That's why she's hurtling. She had back surgery. And she's wearing a corset, a back support. But she's very happy with her ankle replacement. So in retrospect, I could have skipped the supramalleolar osteotomy and done the total ankle straight away. I think that would have been the best in her. And finally, this is a valgus case with a flexible flat foot. So you can see here the flat foot and the valgus. Now, as we got better, we were able to do these as a single stage. So now I reconstructed this one with a single stage surgery. So I put in the ankle replacement, and I found that her heel looked fine, so she did not need a calcaneal osteotomy. But there was still a sag. So I went on the medial side. I did a flexor digitorum longus transfer to the posterior tibial tendon. I reconstructed her spring ligament, and I did a cotton osteotomy. And you can see now her alignment is much better compared to before. But this is a single-stage surgery. I was able to get away with it in a single stage. So I think the take-home message is currently there are many other options that can save the ankle arthritis. While I do agree with all of you that the younger patient with a very stiff ankle, post-traumatic, you should do an ankle fusion on him. But if you have a relatively younger patient, these are my indications, and all of them have good midterm to long-term data. The supramalleolar osteotomy is indicated for early asymmetric or malaligned ankles in a young, healthy, active patient. The distraction arthroplasty is for symmetric arthritis, mostly young, mostly male, active patients. And then the total ankle is reserved for the 50 years old or older, or 45 years old with rheumatoid or older with very good results. These are my mentors from New York, and this is my family and my 4 kids. I thank, of course, the group yesterday for attending the cadaver lab. We had a very, very nice discussion. It was a true pleasure. I would personally like to invite you to the American Orthopedic Foot and Ankle Society meeting and the Egyptian Foot and Ankle Society meeting at one point in time. Thank you again for the Panama Orthopedic Association and for having me today.
No sé si hay alguna pregunta por parte del público.
Thank you, Haleem. I really like your experience. I have some questions. When you make distraction in the ankle osteoarthritis, you make arthroscopy to take out the osteophytes, or you only make the distraction and that's all?
That's a very good question. So yes, you can either do arthroscopy or you can do a minimal anterior approach to the ankle, or sometimes you can do very small medial and lateral approaches. Do take the osteophytes, but arthroscopy is better because you can see the surface. You can clean it, like do an abrasion. And when we were doing these, we injected stem cells. So we would take bone marrow from the iliac crest, spin it down. Do you have the BMAC machine here, the bone marrow concentrator? I concentrate the bone marrow, and then I take the osteophytes, distract the joint, inject the BMAC, and let it sit. And then I put the frame on.
Do you have a limit of the danger if the damage is more than 50%, or you don't care about anything of that?
No, actually, we did it on patients with stage 4, bone on bone, and they did very well. The key is you want to open them up as much as you can. So how much should you distract them? Anywhere from 1 to 2 centimeters. The problem is you distract them acutely, and they start having tingling and numbness because you distracted the nerves. So I would tell you, go to 1.5 centimeters, and if the patient is tolerating it, bring them back every week and distract them 1.5 millimeters once a week for the next 4 weeks. This way you get to your 2 millimeters gradually, okay? But you extract them 1.5 centimeters acutely, and then the extra 1 millimeter a week until you get them out. Keep them in the frame for 3 months, and that's the only downside. A lot of patients are not going to tolerate the frame, and especially females. And that's what they found in the study. Males tolerate the ring fixator more. They can walk with it. I had a patient swim with it. They can ride a bicycle. They do crazy stuff with it. But males tolerate it better. And then after 3 months, get x-rays, make sure that the joint is moving. You put hinges so that the patients are moving up and down because the cartilage takes nutrition from the synovial fluid. And then after you take the frame off, you saw the x-rays. You have a nice space. It's not going to be perfect. It's going to shrink a little bit, but it's still going to be there.
¿Alguna otra pregunta? Le encanta, le encanta.
I'm the guy. Okay, well, about your approach. Okay, you make lateral to medial. When you have, if you have, like, you need to make correction, you prefer always this approach, or you make more lateral, or this type of new approach?
Yeah, so the deformity dictates my approach. So if I have symmetric deformity, I'm going straight midline. If I have the good thing, are you talking about distraction, correct? Distraction arthroplasty? Ankle replacement. Yeah, again, you're talking about my anteromedial approach. You'll be amazed. although going all the way distal medially like this, the flap is going to be very mobile, okay? Like when we do total knees, if you have a valgus deformity, you still do go medial parapatellar, correct? And you're able to lift everything and go and expose it. And that's how I think of ankles. If you think of ankles as a total knee, it's going to be very simple. So I lift that flap in its entirety. And then deep, I go through my plane, which is pretty much the same plane as you would go with an anterior approach. And I can fix a varus or valgus deformity accordingly. But in my experience, and I know you did an anterolateral approach on some of your ankles, in my humble experience, going anteromedial is the safest. It protects your nerves, protects all the important tendons, and at the same time, it gives you adequate exposure to the joint. All you have to do, even in valgus deformities, is just get your incision a little bit distal. Slightly bigger incision, but much, much better exposure.
¿Alguna otra pregunta, además del doctor Moreno? Bueno, si no hay ninguna otra pregunta, thank you very much.
Thank you, Dr. Gonzalez. Thanks, everyone.